I appreciate that. Here we are on a webinar on psychopharmacology. We are broadcasting from Asheville, North Carolina, actually in the offices of InnerQuest Psychiatry. It's a psychiatry private practice that Dr. Cruz and myself and both are at. We're trying some new software today that we're very excited with. This has been a nice new feature that we're opening up. There may be a few glitches today, hopefully not, but we will try the new software and see how that goes. I'm going to move my camera around. That's too much. Okay, that's probably good there. Okay, and feel free to give us feedback about it. We're excited to see how things go with that. So let's go ahead and get started. Psychopharmacology 2013, Confessions of a Jungian Psychiatrist. That's the title we decided to go with today. Let me see, next slide. There we go. We're going to start off with a poll right away and bring up the poll question in just a moment. And the poll question will be, what is your profession? We thought we would get a sense of who's joining us today. Your options will be Jungian-oriented psychotherapist, non-Jungian psychotherapist, prescriber, etc. Mine is probably going to pull up that poll in just a moment. Yeah, there it is. So take a minute or two and click on who you are with that. And I'll do that as well. I'm going to click that and vote. The poll with that, hold for that, and then we will go forward. We'll want to go back to the slides as soon as we can. We can go ahead and close that and share it, and we'll see what pops up with that. There it is. Okay, excellent. Hopefully everybody can see this. Raise your hand or type in the chat if you can't see it. But you should see a pie chart in front of you. It looks like we have a good third are Jungian-oriented psychotherapists. Excellent. Then we have a few non-Jungian therapists, prescribers, 16th not in mental health field, and other. Excellent. Well, good. Well, thank you. That gives me a sense of who's in our room today. We'll go back to the slides. Okay, I'll take over from here. A quick poll. Okay. Disclaimer. We've already had one disclaimer. I'm going to give you maybe a couple more. I'll just read this one because it's pretty important. This seminar is meant to be a general review of psychiatric medicine and some treatment options. Do not try this at home. Prescribers have many years of advanced training. All dosages and medication information is meant for general knowledge and not for any specific patient or treatment option. What we're meaning with that is please utilize this information, but don't take this as gospel truth. Don't try to change patients' medications. Don't do things based on the information today here. Any prescribers, obviously you have a lot of resources available to you and utilize those tonight. But I do want to give you an overview of psychiatric medications and a sense of how we do things with that. But obviously need more than just a seminar to prescribe. A lot of this we've already talked of, but I'll just say it again real quickly. You probably noticed there's an attendee list on the left-hand side. I'm going to scroll down. That might allow you guys to scroll and see it too. I'm not sure if that's the case. But I say that because your names may be on there. And if you don't like to have your name on, you can sign off, sign back on now with a different name or just anonymous, which is fine as well. We are recording this session. We've already mentioned that. I do want to talk about clinical information today. So if you have a challenging client or patient you'd like to talk of, we can do that, but with certain bounds. Obviously, with HIPAA and confidentiality, we don't want any identifying data whatsoever broadcast across the internet. But if you want to talk in generalities, if you have a patient who's been on these kind of medications, what's worked, what hasn't worked, I want us to be able to talk along those lines, but just change the information or talk in generality so that nobody would know any confidential information. And we'll break every so often. Again, if you have a question about a client, let us know. The raise your hand button is a very important feature. That's in the lower right-hand corner of the attendee list. Looks like a little smiley face. And when you click on that, as you gives you some options. You can agree, disagree with things, ask me to speak louder or softer, or if you need assistance. But the raise your hand on the top is the one I want to focus on. So at any point, feel free to click the raise your hand. I may not stop immediately to take questions, but at the next break point, every hopefully 15 or 20 minutes, I'll ask for questions. I'll know whose hand is raised, and we'll have you ask the question. The fun part about this is we can do it as a mini internet community, meaning once you raise your hand, I can open up your webcam and your microphone, or at least ask permission to, and I think you actually do the clicking on it. With that, we can see and hear you, and you can ask your question directly, which is kind of nice. If you do that, turn down your speakers, because the speakers will give reverb, most likely. So if you open your microphone, turn down those speakers. And if you're too shy, too introverted, that's fine. You can email us a question, or you could type in the chat, but we're asking to do email so we can sort it a little bit easier, but you can use the chat if you need to with that as well. So remember that, and please do ask questions. Okay, we're going to start with just a little side piece. We're going to talk a little bit later about some Jungian aspects of prescribing. But I put this slide up there to say, what is the archetypal energy we're constellating when prescribing? This question could be answered in any number of ways. There's an infinite number of ways of answering this question, but I was thinking about it myself. The one that came to my mind was the wizard's potions, the learned wizard with secret knowledge of chemical potions that will change the mind. Not that everybody comes in with those thoughts, but you'd be surprised at the number of patients I see that you really have that feeling that they're seeing us as the holder of some sacred, secret knowledge, and that knowledge and that potion of concoction that we give them, in essence, will change their mind in some ways. There's some truth to that. Medications do affect mind functioning. But this is one archetype that I run into a fair amount, and we can talk more about that in the discussion phase if desired. Thus, this would be a budding psychiatrist. This is the potions class from Harry Potter. I forget the name of the professor there, but I'm sure some of you there might know. Anybody who knows the name of the professor, type in the chat, and that'll be a test question. You'll get a bonus point if you can type in the name of the professor in Harry Potter. But anyway, Harry Potter, the Wiz class, that's a little bit of what prescribing medications can feel like at times. Okay, next poll question. I believe psychiatric medications are prescribed too much, too little, just about right, or in between. So let me see. I'm going to, already Ryan's on it. We'll go to the poll question. And are psychiatric medications prescribed too often, too little, just about right, or somewhere in between? There are your choices. And if everybody can take, 30 seconds, click one of those. I'll click one as well and vote. Full live that are joining us live or recorded, and I'm sure we'll probably get another 10 or 15 as the 2 hours progress. Off the country, international, we're really excited to get quite a few. Okay, here we are. So wow, so 60%, that's the lion's share, say too often and should be prescribed more reluctantly. Excellent. 20%, much too often and should be reserved only for the most severe cases. Purple is just about right, and darker green is not enough. So clearly the not enough got the very little response. So the big one is somewhat too much. And I'd agree with that. That's actually what I voted for as well. I think it's far too easy. Yeah, thanks. Go back to the slides if you would, Ryan. It's far too easy to prescribe medications quickly. And I think the family practice physicians probably get the most pressure along those lines, patients wanting a quick fix. I would hope psychiatrists are a little bit less likely to do so. But again, click down there. There we go. A little bit. But yeah, I think there's a sense in our country that medications are quickly prescribed, and that poll suggests that many of you all feel that way too, as do I. Okay. Why might I prescribe a medication? I'm a psychiatrist. I've got a fairly busy private practice. This is the room I can consult from right here in my office. Why might I prescribe medications? There's three categories I broke it down into. One is the patient has strong psychiatric symptoms that I'm convinced will respond to medications. And schizophrenia is a good example of that. And with schizophrenia, I've got no qualms whatsoever about prescribing medications. With one exception, we'll talk about psychosis later on in the talk of is there ever a sense that psychosis can be therapeutic. But for most patients with schizophrenia that have overwhelming symptoms, that are disorganized, hallucinating, can't function in life, it's pretty clear, and the evidence is clear, that medications help those kind of patients quite a bit. The next one is in between, patients that have moderate psychiatric symptoms that probably would respond to medications. Depression is a good example of that. It's not quite as absolute as schizophrenia or maybe bipolar is, but we still very often prescribe medication for depression because the symptoms seem severe enough and we think they will respond. The bottom one is patient has fuzzy psychiatric symptoms that might respond to medications, but they've been referred to me and they have a strong expectation to begin medication. And that's even more true for the family physicians out there. And that might be a psychosomatic symptom with strong anxiety that might get better with medications, but there's a lot of other complex components to that. And of course, psychotherapy, really all three of these can be and usually is indicated, but the lower one has a lower response rate, and versus schizophrenia is a pretty clear piece. Why else might I prescribe? I'm embarrassed to put up this slide, but with the title Confessions of a Jungian Psychiatrist, I thought, well, what's the economic incentive to prescribe? And this slide, I think, is quite striking. This is really mostly this year. Up until 2013, there wasn't such a disparity between an hour of therapy and an hour of therapy with medications. But they changed all the CPT codes. Any of you clinicians know that quite well. January 1st, they changed the CPT codes. Those are the codes that are procedures that we get paid for. And for psychiatry, it varies via insurance, but look at this one. $112 for 60 minutes without medications, and $152 with. And go ahead and raise your hand. Anybody has a thought about this? And I bet you everybody in this room has a thought about that. But if somebody wants to share a thought, let's try our Open Your Microphone system. Go ahead and click on that smiley face on the lower right-hand corner of the attendee list. Click Raise Your Hand. We'll try opening a microphone, but I bet you somebody out there has a burning comment on this. What do you think of insurance companies that will pay psychiatrists $112 for no medicines, $152 for the exact same therapy hour with medications? Do we have any brave souls? Oh gosh, not a one. Doesn't somebody want to comment on that? That's such a controversial piece. Nope, okay. No, folks. I've got some feedback. Is that somebody's open mic, or is that you, Ryan? Okay. Well, anyway, if anybody has a comment on that, we'll come back to you. And Ryan, if you notice a comment on somebody, we can do that. But anyway, I was pretty shocked this year when let me go back to it, when the fee schedule came out and there was a $40 difference. So if I add medications to a therapy session, I get $40 more. It's hard not to be influenced by the economics of that. I try not to be, but you are sometimes. So how am I doing? These statistics I just pulled together, but I think are reasonably accurate. Yes, as a psychiatrist, almost every patient referred to me is referred with an expectation of medications. I get an occasional psychotherapy case because they know I'm a Jungian-oriented psychotherapist as well as a psychiatrist, but most family docs and general practitioners are referring to me from the expectation of being on medications. And of those, I bet 95% come with the expectation of being on a medication. And I would say probably 90%, 9 out of 10 are actually on medications. So in one way, you could say I'm doing horrible because 90% of my patients are on medicines and I'm perhaps overprescribing. You could also say that I've reduced the number of medicines compared to the number of people requesting medicines. So maybe I'm not doing so poorly with that. But these are the kind of numbers that at least I, as a psychiatrist, are aware of with that. So we're going to move on to psychopharmacology, and I've divided that into a few elements, into really 4 sections. And those 4 sections are, what I'm calling uppers, downers, squeezers, and heavy downers. So obviously these are really more mnemonics than anything else, but dividing into 4 categories of what are medications that by and large raise the central nervous system activity, what are medications that lower central nervous system activity. Squeezers means that you're compacting mood, really mood lability. Those are mood stabilizers, ones that try to prevent the ups and the downs. And the heavy downers are more really antipsychotics that are stronger at really bringing down mood and really central nervous system activity overall. Some would say through the dopamine system with that. So, oh wait, there is a comment. It was a chat, so it wasn't a audio. This is from Barbara, who says pharmaceutical greed without consciousness of psyche. Yeah, absolutely. I could spend the entire 2 hours talking about the pharmaceutical industry and what we see as psychiatrists and the pressures that are there, often to prescribe much more expensive medications with the illusion that the more expensive medications are better or more effective, while much of the data suggests they're pretty equal for most of the categories, yet there's a strong psychopharmacologic bias out there towards medications, not to mention the price. Barbara mentions pharmaceutical greed. Abilify can cost $400 to $500 a month, and not to pick on just Abilify, any of the antipsychotics that are non-generic are around that range. Provigil, horribly expensive, and somebody's obviously making a lot of money with that. Feel free to keep chatting. So any more thoughts on this or anything as we go ahead and type it in the chat button. I know we said to email them out, but let's try using the chat some with that. I kind of like Barbara's thought. Okay, let's keep going. So we've got uppers, downers, squeezers, heavy downers. So the uppers would be antidepressants or stimulants. Downers would be sedatives or sleepers. That's really the same thing, but some medications are marketed more as what's called hypnotics, which are sleep medications, Ambien being the prime example of that. Others are more pure sedatives. Klonopin, Valium, Xanax. Squeezers are mood stabilizers or antipsychotics. Both are used to try to decrease the range of mood reactivity. Then heavy downers, what I'm calling the stronger piece, are the higher dose antipsychotics or the older antipsychotics, the Haldols, the Thorazines, as well as the newer ones, Abilify, Zyprexa, the others. And we'll be talking about each of these categories in a fair amount of detail relatively soon. Next slide. Antidepressants, which we're categorizing as uppers, meaning they increase the level of activity in the central nervous system. This is often through norepinephrine and serotonin, as well as dopamine. We'll talk a little bit about that with the various antidepressants. And they raise the level of the neurotransmitters in the synapse, which is part of the mechanism why they work. There's much more complexities in the mechanism, but that's the kind of quick and dirty with that. Diagnosing depression, many of you know this particular clinicians, but there are certain what's called neurovegetative signs of depression. The mnemonic for that is SIG-ECAPS, S-I-G-E-C-A-P-P-S-S-S. And somebody write in the chat button what that mnemonic is for. It's for a Latin phrase, and let's see if anybody knows how they developed that mnemonic, SIG-ECAPS. Anybody know why SIG-ECAPS was chosen as that? And I'll give you a minute or two to put it in the chat box. If nobody does, I'll tell you in the end of the minute. Going down the symptoms, you have S stands for sleep, and that sleep changes. For depression, that can be increased or decreased. People have hypersomnia or insomnia with that. I is interest lost. It's called anhedonia, is the jargon name for that. Anhedonia refers to a loss of interest, so you're not as motivated to do things. Your energy and interest in activities is down. G, a couple of chat questions. Can we get a copy of your slides? We'll prepare a handout and we'll try to send that out to people. That's a good idea. The other chat, how much of the $40 difference reflects reimbursement or higher malpractice insurance. That's a good point. I might get back to that one, but I like that chat thought as well. Anyway, G, let me keep going with this for now. G is guilt or hopelessness. Patients with depression have a high amount of hopelessness, despair, guilt, shame. E is energy loss. They have less energy. C is for concentration. The concentration is reduced, for patients with major depression. Appetite changes. Appetite can be increased or decreased, with that. Psychomotor agitation, psychomotor retardation. That refers to physical agitation, and that's really what you see in the consultation room. Psychomotor agitation, they're moving, they can't sit still, they're tapping their foot, they're kind of anxious. And with psychomotor retardation, they barely move at all, they have very monotone voice, and you fall asleep during the session, which is not good. But it can be profound. Psychomotor retardation, and its most profound would be, I'm spacing on the name of it. Well, I'll get back to that. But psychomotor retardation can be very profound, where there's no activity and they're barely moving, with that. Sexual loss is common, with depression. Suicidal thoughts, of course, and are very problematic when they are. And S just refers to sadness. That kind of goes without saying. They're going to have what we call dysphoria or sadness with that. Okay, so that's depression. That's diagnosing depression. Let me comment on that piece. The difference reflecting the malpractice insurance, that is a good point, in that as a prescriber, it's much more likely to be sued, for that. Our malpractice is probably 10 times or so higher than the non-prescriber. My wife is a social worker, and when I see her malpractice bill, I am jealous, every year, because hers is a fraction of what ours is, and ours keeps going up, and lawsuits are prevalent. So that, I think that is true, and maybe it reflects the nature of the training and being a physician. But for me in the room, I'm equally trained, I'm equally likely to be sued in many ways, yet I'm making a certain amount if I add medicine and a certain amount if I don't. So that's a internal kind of struggle that I'm aware of when practicing. Okay, antidepressants options. There's 5 main SSRIs and then 6 non-SSRIs. Somebody type in what SSRI stands for. That's the next question. Type in the chat what SSRI. Let's see if we can do that first. In the meantime, I need to tell you what SIG-E-CAPS stands for. SIG back, SIG-E-CAPS. SIG is Latin for prescribe, E is short for energy, and CAPS for capsules. So SIG-E-CAPS, prescribed energy capsules. And I don't know why that mnemonic was developed. That's a very old one. When I was in medical school at Duke, gosh, 20, maybe 25 years ago, that was the one we were taught. And that's stuck with me substantially. Yes, we've got 2 winners with SSRIs in the chat box. To this day, when I'm seeing a patient, I'll write out SIG-E-CAPS, and I'll circle the symptoms that they have, and I'll X out the ones that they don't have, and that's an effective way of diagnosing the symptoms, or at least listing the symptoms down. So both of you were right. Arnie and Susie were both correct. It is indeed selective serotonin reuptake inhibitor, and that refers to the synapse. So the nerves within the brain, when the nerve cell jumps from one neuron to the next neuron, there's a synapse between the two, very, very small microns between the synapse. And serotonin, or norepinephrine, or dopamine, but serotonin in this case is secreted into it. And if you block the reuptake of serotonin, more serotonin stays in the synapse. And that's a theory. It's not 100% proven, but that's a theory of why medications, why SSRIs might be effective if they increase serotonin. It is important in the side effects. So it's important to know which ones, if you're prescribing, are serotonergic, which ones are less serotonergic, because the symptom cluster can be different with that. Questions about generics. That's a great question. I'll get to that later in the next part. But yeah, I like generics by and large, and think it's criminal to have to pay hundreds of dollars for non-generics. But we will definitely talk about that in a moment. Okay, these are the 5 SSRIs, and they're all pretty similar with some rare exceptions. The drug reps will come in and tell you they're drastically different, and of course theirs is always the one that's drastically better than all the rest. But the research is pretty clear that they're all pretty similar. They have similar response rates, and they all affect serotonin. And that's important because they can all cause serotonergic syndrome, which can be too much serotonin in the central nervous system, can cause rigidity, can cause delirium, sweating, a number of symptoms. And you see that more likely with the serotonin ones. Even though they're all equally effective, they're not all equally effective for given patients. So I have patients that do wonderfly on Zoloft and horribly on Lexapro, and vice versa. They may do wonderful on Lexapro and horrible on Zoloft. So even though they're equally likely to be effective for any given patient, on average, for a specific patient, you might have to try different ones to find. And let me click the next one. I think I go into a little more details. Okay, we'll come to that for a moment. Just going through these real quickly. Prozac is one of the oldest. It's been generic for a long time. Came out in the 80s, I believe. Lots of books and lawsuits have been written on it. Long half-life, stays in the body for quite a long time. Prozac, when you stop Prozac, it takes about a month to get out of your system, which is very unique. Most medications are out within a few days. So there's not nearly the withdrawal effect you get in Prozac as you do with the others, and it can be good if you really want a smooth system. Rick, a good friend of mine, says max dose is now 40. Oh, he's correct. When we get down to Celexa, we need to change the slide because they have indeed changed it. Rick Smoot, PsyD, psychologist, works here in our office. A friend of mine from the military from 25 years ago is reminding me that Celexa should be 40. So right there, ooh, look at that. I can actually I didn't realize I could do that. So 60 is incorrect, and that is indeed, look at that, 40. So 40 milligrams of Celexa. You can go beyond 60, but there's a significant risk for cardiac arrhythmia. So on Celexa, cross out that 60 and put 40. Thanks, Rick. I appreciate that. Although maybe that's his wife, Robin, that just nudged him with that. Anyway, yes, indeed, Celexa is 40 milligrams. Of these, they're pretty much all generic now. Lexapro was the last one to go. So they're all generic. They're all fairly inexpensive in the generic form. Anything else that stands out? Zoloft, maybe occasionally for PTSD, might be used a little bit more regularly for that. Lexapro has a little bit more serotonin oomph with it. Okay, so let's go to the next slide. Okay, poll question. Why was Pristiq developed? We're going to talk about Pristiq in just a moment. Was it a substantial improvement over the other antidepressants available at the time, as a quicker onset of action, or, and we'll put up the other poll question in a moment. Okay, it was a substantial improvement over the other antidepressants, or it's a cheap ploy by the manufacturer to try to extend its patent life by creating a knockoff medication of one that already owned. So go ahead and vote on that. This question comes up a lot. It comes up with Lexapro and Celexa. It comes up with Pristiq and Effexor. There's a few others that have done that as well. So Brian, go ahead and close the poll and open that up. We'll see. Yeah, I didn't think I'd catch too many people on that. 22% believe that it was a substantial improvement, and 77.78% believe that was a cheap ploy. This is opinion, of course, and this is being recorded, so I hope the manufacturers aren't listening into this. And actually, it's a little bit of both. I mean, the 22% aren't completely wrong. Pristiq does have some nice aspects to it, particularly if somebody does well in Effexor, but side effects a little bit too much, you might go to Pristiq. It's always suspect, though, when it comes out, right as the other one is going generic. And let me get back to these slides. Sorry. Well, let me keep talking with that. Ryan, go ahead and see if you can get back to that slide. If not, I'll click on it in a moment to do that. But Pristiq came out right as Effexor was going generic. And thus, there's always that question of of are they kind of prolonging patent life, and you'll see that with medications. So you have to be a little bit suspect when you see a brand new medication. Is it really an advantage? There's Pristique right there, or is it not? So these are the 6 non-SSRI medications. Wellbutrin, Effexor, Pristique, Cymbalta, Remeron, and Viibryd. There are some others, too. I don't want to say these are the absolute only ones, but these are the ones you see most often. There's some older medications called tricyclic antidepressants. There's Luvox as well. That's actually more of an SSRI, but when looking in charts and dealing with patients, these are ones you're going to see quite commonly. If we break it down, if we go to this next slide and look at the details of it, these 6 actually are quite different from each other. If you remember, the 5 SSRIs we said were all pretty much the same. They had similar effectiveness. They worked in similar mechanisms, and individual patients were different, but the side effects overall were pretty much the same. With these medications, they really are quite different. We'll start with Wellbutrin, 300 milligrams per day. I decreased that dosage as well. 450 is the official FDA dosage, but there's been some recent data that once you get beyond 300 up to 450, the risk of seizure goes up substantially. So in this day and age, with the rare exceptions, I usually will max out the Wellbutrin at 300 milligrams to avoid that risk of seizures. Some will say 450 though on that. Wellbutrin, which is generic and comes really in 4 formulations: Wellbutrin immediate release, Wellbutrin sustained release, and Wellbutrin extended release. So IR, SR, and XL. The XL is the easiest to use. It's once a day dosing. It's now generic, so it's the most common one that we use in our clinic here. The nice thing about Wellbutrin is it's the most energizing of the antidepressants. So we get the most increase in energy from it. So if you have somebody with a very lethargic, slow depression, Wellbutrin is really nice from that perspective. I misspelled antidepressant. I'm sorry for that. There's less weight gain with Wellbutrin, partly because it's energizing, but it doesn't have as much appetite stimulation as the other antidepressants might have, and it's used for smoking cessation as well. Somebody type in the chat box of what brand name was marketed under for smoking cessation. This was particularly true maybe 10 years ago. We saw a lot of people promoting it for smoking cessation, had a specific name. Oh, there we go. Jan is correct. Zyban, Z-Y-B-A-N, was indeed the name was marketed under, and we used to get a fair number of folks wanting Wellbutrin for smoking cessation. Zyban, you don't hear too much about it anymore, but we can still use Wellbutrin for that. And it was the exact same medication. They just changed the name, maybe changed the color. I forget if they did or not, but otherwise was identical to regular Wellbutrin. The Effexor XR, phenylephrine. I should have put generics down here as well. I'm sorry. This is bupropion for Wellbutrin and phenylephrine for Effexor. Effexor, phenylephrine, the dosage range is 75 to 225 milligrams. Some folks go beyond 225, but 225 is the FDA max. They really shouldn't do that unless you have a clear reason to do so. Some believe it's better for treatment-resistant depression. I found that somewhat the case. Partly that's some drug rep hype on it, but occasionally if you have a patient with strong depression that's not getting better, Effexor may well be a medication we would turn to. Effexor is nice because it's dual acting. Wellbutrin is dopamine. That is just the dopamine neurotransmitter gets affected. With Effexor, you get norepinephrine and serotonin. So it's got 2, as opposed to SSRIs, which are mostly serotonin. So Effexor is a dual-acting norepinephrine and serotonin, and there's the theory that that would help more with severe depression. And that's not 100% proven, but could well be the case. Pristique really is Effexor. It's a metabolite of Effexor. So Effexor becomes Pristique. So therefore, it's got the 2 neurotransmitters as well, norepinephrine and serotonin for this one. But again, very similar to Effexor, not generic yet, so you're going to pay some money for that. Cymbalta is a nice medication. It's also dual acting. So I'll put a little 2 marks. Just like all these, the dual acting is norepinephrine, adrenaline, and serotonin. It's also better for pain, and you see it marketed a lot for that. Cymbalta does seem to help with pain. Initially, I thought that was yet again drug rep hype on it, but it does seem to be the case. Fibromyalgia and really any pain, Cymbalta doesn't help dramatically, but does improve pain to a modest degree for some folks. So if you have somebody with pain and depression, it's not bad to use Cymbalta for that. Again, it's dual acting. The range 30 to 120 milligrams, for that. The drawback is price. Cymbalta is not generic, and so it really is expensive. So if you got a patient who can't afford it, the Cymbalta is problematic along those lines. Remeron is kind of multiple. It's serotonergic, it's noradrenergic, and it's antihistaminergic. So I will say 3 with that. And the antihistamine effect, just like Benadryl, you take Benadryl, which is an antihistamine, you get very sleepy. Remeron has a lot of sedation to it. It's one of the most sedating antidepressants we have. It also helps with appetite, and that can be good or bad. If you have a patient who's losing weight too much and needs to gain some weight, they're too thin, they have no appetite, they have some nausea, stomach problems, just not doing well, and not sleeping at night, Remeron's an ideal choice for them because it will stimulate appetite and it will likely allow them to get some sleep as well. It's a little funny to dose. It can go in 2 directions. Sometimes the lower the dose, the more sedation with Remeron, and that's a factor of balancing these various neurotransmitters. At the higher dose, you get more norepinephrine. At the lower dose, you get more antihistaminergic. So actually the lower dose supposedly is more sedating and the higher dose is less sedating. Now that's not always the case. So if you prescribe it, you've got to tell patients, warn them both directions that I'm going to give you this dose. If it's too sedating, we'll try decreasing or we'll try increasing. And one or the other will help. And you won't really know because it's so individualistic with the patient. But it is quite sedating with that. Vybrid is the latest and greatest. It is in between. It's partly an SSRI, but it's really not. It's a kind of novel serotonergic agent and uses some presynaptic receptors, with it. We're not sure if that really matters that much. It may or may not have a therapeutic difference with that, but it's nice that it has a different mechanism of action. So if a patient hasn't responded to the traditional medications, we'll use Vybrid often with that. But again, very pricey. It's brand new, and you'll pay a lot of money for that. There's less sexual side effects. That's probably true. The jury is still somewhat out, but it does seem to have less sexual side effects. So the SSRIs, which have the most sexual side effects, which can be loss of libido or delayed orgasm, that's probably the larger one we see, both for men and women. They can have a hard time ejaculating or achieving orgasm. And if that's the case, Wellbutrin is pretty good along those lines, and Vybrid as well. So if you have somebody with sexual side effects, these 2 will be ones to turn to. These others in between as well, but SSRI is probably the worst along those lines. The problem with Vybrid are stomach issues. Folks who prescribe it with often have some nausea to it. You can avoid that by staying at the 20 milligrams, not going all the way up to 40 milligrams. That sometimes has been effective for that as well. So let's pause for a moment. Not that we have to take questions now. Let me see what the next slide is first. Yeah, before we get to Lamictal, which we'll talk about in a moment, go ahead and click the Raise Your Hand button. Again, that smiley face on the lower right-hand corner of the attendee list section. Anybody has a question about any of the antidepressants? That could be the SSRIs, the non-SSRIs, or other pieces. We'll have further options for questions later. And questions can be raise your hand, which is what we're urging. If you're a brave soul and don't mind opening your microphone and or webcam for a moment, click the raise your hand. If you're shy and want to just type it out in the chat box, go ahead and type it out there. Or if you email it to Ryan at info@ashevilleyoungcenter.org, he can read them there. And Ryan, just break in. If you have any burning question on antidepressants, just let me know and we can do that. I see a soul with their hand raised. Let me click that. And Rick, that's you, Rick or Robin. Yeah, Rick Smoot or Robin Miller. I'm going to give voice and or video to you. And click probably accept, and I bet you'll be able to talk into your webcam in just a moment.
There you are.
There
your
you are.
video's
Your video's going to pop up.
I
hope you want that to happen.
Yep.
Hello.
Yep.
Turn down your speakers.
Turn down your speakers. We're getting an echo.
Okay.
Okay.
Can you hear me okay?
Or just, yep. Turn them almost off again. Yep, just
I don't
fine.
hear you.
Rick Smoot, PsyD, friend of mine.
Can you hear it? Okay.
Yeah.
Yeah, I just had a quick question. In regards, can you hear me okay, Steve?
Yeah, we're fine.
Am I
turn off the
through
speaker
okay?
when you ask the question,
okay.
then turn it back on. Yeah, you're good.
Okay. I'm not a physician, but I've in the past when I've worked with other psychiatrists, sometimes they will add one of these non-SSRIs as Mutrin when a person is having sexual side effects with the SSRIs.
Exactly.
And I was wondering if there's really any data to support adding a non-SSRI to an SSRI or other medication in order to increase sexual drive or sexual arousal and so forth.
Yeah, excellent question. Hopefully people, okay, so go ahead and turn off your.
Okay, so go ahead and turn off your.
Okay, I've just removed your microphone setting, but thank you, Braves, for raising your hand with that. Yeah, that is a great question. I'll repeat the question. Do we add Wellbutrin or other non-SSRIs to SRIs for treatment of sexual dysfunction, and is there research data to kind of support doing that? The first part of the question is yes, very frequently Wellbutrin is added to an SSRI for sexual dysfunction. Again, with SSRIs, we see a lot of sexual issues, delayed orgasm, sometimes erectile dysfunction, decreased libido. The best, of course, is to come off the SSRI and change to Wellbutrin or something else. So if they can respond to Wellbutrin alone, it's always better to be on one medication instead of two medications. So the first thing we'll try is coming off the SSRI and going on to Wellbutrin, usually cross-titrate, whether on both for a little bit, then remove the other. Now, sometimes that doesn't work because, say, Zoloft is the only medication they've responded to. They're doing great on Zoloft. They don't do good on Wellbutrin alone. So we're stuck with keeping them on the SSRI, but yet they're still having sexual dysfunction. In those cases, you can try adding Wellbutrin, and we've done that a number of times. That can help the antidepressant more. They might get more efficacy of the antidepressant. They can also get more energy, more drive and motivation. And sometimes the sexual side effects reduce or reverse with that. Again, that's not 100% by any means. I would say in my experience, maybe a third get some relief from that. Other ones are Viagra. Viagra, even for women, does seem to reverse the sexual side effects. That's as needed. So if you're on SSRI and you think you're going to be having intercourse that evening or whenever you're having it, about an hour or so before, if not only does that help erectile difficulties, but can help with the libido, can help with ejaculation, and again, that's true for women as well. We'll commonly do add Wellbutrin and add Effexor. If anybody else has another plan that they've done in the past, go ahead and type it in the chat or raise your hand and we'll open up your microphone. Your question of is there data to support that? I've seen occasional studies on that, and they're sort of mediocre. They sort of suggest that it helps, sometimes do, sometimes don't. So the literature I've seen is kind of mixed with that. It's not as great and robust as we'd like, but it is there to some degree. And again, if anybody has any other data on that they want to chime in on, type it out into the chat or you can open your microphone. There's a question from Susie. Will you clarify the mode of action of Vibrid? I can try. You're stretching my brain a little bit. Vibrid, if memory serves, is a serotonergic medication that uses not just the traditional serotonin mechanism, but it goes to the presynaptic receptor. So if you have a synapse, it's going to be very crude, but that's the first synapse that goes to then the body of this nerve, and then it goes this way. So the direction of the impulse is here, and this is the synapse. So this is the first nerve, that's the second nerve. Then, of course, this nerve goes to another nerve, and it keeps going and going. That's the synapse right there. So the serotonergic reuptake inhibitors block the little spots right here, which is the ones that, actually here as well, I believe, that bring the serotonin back up. Actually, they're here, but they bring them back into it, and it keeps the serotonin in here. The presynaptic would be prior to the synapse, so it would be in this area, and by affecting this, it affects the serotonin level. That's not stated eloquently enough, and I'm sure there's a much more detailed piece, but it's not the traditional SSRI reuptake inhibitor, but it's a presynaptic serotonin space with that. And clinically, that seems to affect those kind of issues with that. Let me go to the next slide. Lamictal is a nice kind of hybrid in between. It is half mood stabilizer, half antidepressant. And because of that, we use it quite a bit. It's most used for bipolar depression. So if somebody has a bipolar depression, Lamictal is really one of the first line treatments for that. Lamictal is actually an anticonvulsant. If you look at when it first came out, it came out for seizure disorders, and then was later found to be helpful for depression, anxiety, and even mood stability. And we've been using it for that for quite some time now. It's gradual. It takes a while to build up in the system, and even more so because you dose it very slowly and you gradually build up over a month or so with it. But it's nice in that it's got very few side effects. There's one, bad skin rash and Stevens-Johnson syndrome, including death, although that's very, very rare. But other than this, which is quite uncommon, it has very few side effects. So most patients I have that are on Lamictal, if they don't have the skin rash, and 90% don't get a rash on it, about 10% seem to get one. But the 90% that don't get a rash have very little side effects. It seems to do pretty well with that. Yet it's good for a kind of mild bipolar and or a bipolar depression. So Lamictal, you'll see a lot of clinicians using nowadays. Stevens-Johnson syndrome is a rash that's a very bad rash. It's not just a typical red, splotchy, penicillin-like rash, but it's a very intense, painful, fever, bad-looking rash. And that's head into the ER and get treatment emergently, but that's very unlikely. It's now generic, which is great, so it's quite a bit more affordable with that. Locally, Ingalls here in Asheville has it in the $3 plans. We've used it there. Some of the other pharmacies don't yet, so it's kind of in between. Some pharmacies are more expensive, some are less. But if you shop around, you can get Lamictal usually at a pretty cheap price. And let me scan for any hand raised. Nope, no hand raised. And if you have any questions about Lamictal, feel free. Len Cruz is going to amplify my statement because I probably botched the vibrid. Len says, I think it's 5-HT1, that means serotonin. So it's a partial serotonin agonist, and the metaphor I use to explain is that SSRI activity can be likened to placing your foot on an accelerator, and a partial agonist is like removing the brake from the steps. Okay, well there you go. That's a even more eloquent way of clarifying it. But again, it's a little bit different within the synapse with that. And I'll need to look that up if the presynaptic piece is right. My memory says it's a presynaptic, maybe partial agonist, but that sounds quite well phrased as well. So back to Lamictal, no hands raised. Okay, side effects for antidepressants. Antidepressants, of course, can have some side effects. The ones we see most commonly are GI, so that's nausea, upset stomach, diarrhea, some constipation at times. Sexual loss, we already talked about, that's quite common. Appetite can be loss or increase. More common is appetite increase, and of course many patients don't like that because there can be weight gain with it. Sometimes there's appetite loss, and Wellbutrin is more likely than others to do that. Agitation, irritability, restlessness, or even suicidal ideation. And of course, suicidal ideation is the most worrisome with that. Really, any antidepressant can cause agitation to the point of suicidal thoughts. This was controversial up until 2 or 3 years ago. We weren't sure if that was an effect from the depression itself causing the suicidal thoughts or the medication causing the suicidal thoughts. Of course, it can be both. It doesn't have to be one or the other. But recent research does suggest that some of the antidepressants can trigger suicidal thoughts. So you always warn patients of that and ask them to call you right away if that occurs. These medications can be sedating or activating. We see both. Particularly with anxiety. If they have anxiety episodes, activation can be more intense. And never stop medicines cold turkey. You really don't want to stop any psychiatric medicine cold turkey, with some exceptions. If they're having an allergic reaction, we'll absolutely stop it cold turkey. If they're having suicidal thoughts, we would probably stop it cold turkey as well. Or Prozac you can stop completely. Prozac is because it takes a month to get out of your system, so even if you stop it right away, you really haven't, because it'll take a while to get out of the system fully. But the others, you really want to avoid, because there is a withdrawal syndrome, some more than others. Effexor in particular, Cymbalta, Paxil maybe, those, and really any antidepressant can have a withdrawal symptom from it. Initiating antidepressant, the trial should last 6 to 8 weeks. If the first class doesn't work, we'll often do a different class. Maybe we'll try a generic SSRI first. If that doesn't work, we may change class to a non-SSRI. But remember, you need to wait a good 6 to 8 weeks, because all these antidepressants, every single one of them, takes a while to kick in. An occasional patient will have a quick response within a week or two, but most patients it's a month to 2 months, 2 to 6 weeks, somewhere in there. So you've got to give time for the medication to really kick in. Always consider the hormonal component. What I'm referring to with that is hormones are always a part of depression and anxiety, particularly in women, but men as well, testosterone. But if you have a lady who is premenopausal, the menstruation cycle can really affect anxiety and depression pretty strikingly. While they're pregnant, that'll change symptoms. Postpartum will absolutely change symptoms when they then go through menopause. And birth control pills are a big factor. If a woman has just changed to a different birth control pill and is suddenly having more or less depression, you need to keep that in mind and look at what are the possible reasons that might be going on, and could the oral contraceptive be helping or hurting with that. And often we work in conjunction with the OBGYN doctors along those lines. Augmentation, this is really more for the prescribers, but we'll sometimes augment with Buspar, which is an anti-anxiety medication, sometimes helps with depression. Cytomel is a thyroid medication that we'll sometimes add to it. We'll augment with Wellbutrin, adding it to another antidepressant, and there are other strategies, and we could do an entire talk on augmentation, but there are ways that we'll mix and match medications. We try not to do that. It's always better to be on one antidepressant as opposed to multiple, but sometimes we have to go on more than one medication. Duration of use, usually 1 year, and then we taper off. That, of course, varies a lot depending on the patient. We'll consider indefinite antidepressant use if they have 3 or more depression episodes, or if they have 2 depression episodes with a severe symptom, early onset, strong family history, suicidal attempts or thoughts, or if they have a recurrence after 1 year. This is all fuzzy. It's rare that we tell somebody you're going to be on antidepressants the rest of your life. In fact, I never say that. But it really just means we might have them on antidepressants for a longer time frame if these are there. But 1 year is kind of the average if you have a kind of a typical depression. Laboratory evaluation I won't talk too much about. Again, this is more for prescribers, family docs, and others. But if we're prescribing an antidepressant, we want to ensure there's not another physical cause for it. The worst thing we'd want to do is give somebody antidepressant medication while there in reality is a different cause of that. So we'll get what's called a comprehensive metabolic panel that looks at liver and kidney and electrolytes and blood sugars. We'll look at a complete blood cell count in case there's an anemia, which can cause depression. TSH is a thyroid stimulating hormone that's ruling out low thyroid gland. We'll look at B12, folate, vitamin D. We're looking at deficiency syndromes that can affect depression. Serum pregnancy, you want to know if your patient is pregnant, if you're going to be adding an antidepressant to that. And testosterone, many men, particularly later in life, have reductions in testosterone, and that can worsen depression, so we'll often check testosterone to make sure there's sufficient levels in their system for that. I don't want to talk too much about this, but this is just to say that there's a long list of medications, and this isn't comprehensive at all. There's many others, but there's a long list of medications that cause depression. And the main point with that is if a patient has recently begun a general medication and within a short period of time develops a depression, suspicious about that new medication, did that cause the depression? So we're often a little bit of a detective trying to piece together, is there anything in the environment that's causing this? And of course, there's diet, exercise, all kinds of other things, sleep, that can affect depression as well. Refer to psychiatry if the depression symptoms are particularly severe or suicidal thoughts. Really should have a psychiatrist managing the medications if possible. If the patient fails 2 to 4 trials of antidepressant by a general physician, we'll often urge them to refer to one of us. If there's a complicating factor, if they're psychotic, if they're manic, if there's bad panic disorder, OCD, eating disorders, severe anxiety, substance abuse, all those are reasons why you might think of a psychiatry referral for that. And then there's more advanced treatments. There's ECT, electroconvulsive therapy, known as shock treatment in the past. There's vagus nerve stimulation therapy. There's soon to be deep brain stimulation. There's a lot of new advances coming on the horizon with that. So that's the first part of the antidepressants, or the first part of the medications with antidepressants. Let me scan down if there's any questions on antidepressants before we move to mood stabilizers. I don't see any hands, but feel free to click a hand raise if you want to. Let me read at the chat. Len says he agrees that he thinks it's a presynaptic serotonin partial agonist. Okay, so I was hopefully right on that. And there's an anonymous email question. How do you choose between the various agents within a class when selecting an antidepressant and why? For example, an SSRI versus a non-SSRI. And once that choice is made, how do you guide the choice within a class? Okay, that's a great question. Let me briefly go back to the slide for that and kind of run through that. Okay, so here are the SSRIs. I've scribbled on it. I don't know how to get rid of that scribble, so I won't even try. But yeah, so the first question is SSRI or non-SSRI? The first choice is, do you want to do a SSRI or non-SSRI? Some of that, honestly, SSRIs are all generic and inexpensive, so we'll often go for that. Some of these are coming down in price. SSRIs, I would say, are better for anxiety. If you have a highly anxious patient, we'll often use an SSRI. So if you need that kind of calming, or if you need a niche for one of these. Most of these has a niche. This is more energizing, Wellbutrin, so it's got more of a increasing energy aspect to it. It's less weight gain, less sexual side effects, so you would choose Wellbutrin for that. Effexor, maybe a little bit stronger, you would choose that one for that. Prestique, I would only use if they did really well on Effexor except for side effects. Then I would kind of change to Prestique. Cymbalta, maybe treatment-resistant, comorbid pain, I would choose that one. Remeron, if they're not sleeping, if their appetite's low. Vibrid, maybe sexual side effects, or you've tried everything else and it's the newest one, so you want to try that. So these, I go by the niches. Each one of these has a different niche. The SSRI question is a little bit harder in that, yeah, here they are. These are all pretty similar, so how do you decide between these? Often I'll go by cost. Zoloft is pretty inexpensive. It's got less withdrawal effects, and it just seems kind of good all around. So it's kind of my first go-to SSRI, for general patient. Lexapro is a little more potency. Maybe if there's some OCD, I might use that one for it. Prozac, long half-life, so if you want something that a patient who's not compliant, not taking medication that's prescribed, Prozac can skip a dose or two and there's no problem with it. And often it's what have they not tried. By the time they get to me, I go down the list and they've been on 90% of the meds. Well, which ones haven't they been on? And I'll often go by that. So hope that answer the question. If there's anxiety, I might go with SSRIs, and if there's a niche to fill, I'll go with the niche. Okay, let me move on. Okay, so section 2, mood stabilizers. And these we're affectionately calling squeezers. These are medications that reduce mood fluctuations, the ups and downs of mood. There are 3 main mood stabilizers. These are the classic. 15 years ago, what were the mood stabilizers? These were the 3 they would answer. If you asked 20 years ago, they would give you the same answer. Lithium, Depakote, Tegretol. All 3 are classic mood stabilizers. They're all used for bipolar disorder and have a pretty good track record with that. They're all somewhat toxic, though. These are stronger medications, as are the antipsychotics. So you want to be a little bit careful in using these and make sure they really need it. Lamictal, less toxic, so we use Lamictal more often. Of these 3, there are certainly differences we'll want to talk about. Lithium is old. This is one of the oldest medications, been out decades and decades, probably 1940s or 50s. If anybody knows exactly, somebody Google when lithium came out and type it into the chat box. I want to say 40s or 50s, but this is an old medicine. It's been out for forever. And it's natural. The thing about lithium is if you look at your periodic table of elements, y'all remember that from high school? Remember that? Looks like a castle and it's got all those boxes in it. And one of those boxes is lithium. I have no clue where on the table. I'm sure we could pull that up on the web. But somewhere on this table is lithium, meaning that it's a mineral. It's mined right from the ground. It's a salt, lithium carbonate, lithium chloride. And it's a natural ingredient, which really none of our medications, by and large, are. All the rest are synthesized. So it's got an appeal for that. It's got some renal toxicity, kidney toxicity, so it builds up in the kidneys. You need to be a little bit careful with that. There's some nausea, diarrhea, tremor, and at the high levels, you get a fair amount of tremor with it. Sedation, weight gain. So that's a significant load. But on the lower dosages, if you say 0.3, that's the blood levels. Blood levels can be 0 to, say, 1.4. 1.4 would be really high. If you keep them at 0.3, 0.4, it seems to not have nearly as many of the side effects. And Len says lithium first appeared in 1949. Okay? So 49. I kind of guessed right. I said 40 or 50. So again, 1949 it came out. So this is an old medicine with that. And you follow blood levels. All 3 of these, you check blood levels, with it. Where you want to monitor the blood levels to keep them in a very kind of tight window. If it goes too high, they get toxic. If it goes too low, it can be subtherapeutic. Depakote also has been out for quite a while. There's liver toxicity with it, some nausea, diarrhea, tremor again, sedation, weight gain, hair loss. I saw a patient today that's lost some hair that may well be from Depakote, and so we are taking her off Depakote today because of the hair loss from that. There's another. Jan Stannard says first recorded use in 1871 or 1886. So there's a bit of a controversy. Len thought 49. Jan says 1800s. Gosh, interesting. So if it goes over the 1800s, then it's absolutely the first medicine. And that could be modern psychiatry versus kind of earlier usages of it, but there's one report from 1886. Okay, Tegretol is a anticonvulsant. These 2, there's a difference between these 3. Lithium is a element on the periodic table. Some are on that table. These 2, Depakote and Tegretol, are anticonvulsants. So they're anti-seizure medications and still used to this day for seizures, equally as much as they are for bipolar illness. So Depakote, valproic acid, is a anticonvulsant for mood stability. Tegretol, also anticonvulsant. The big thing with Tegretol is there's lots and lots of drug interactions. Tegretol really can ramp up the liver. The liver becomes almost, I don't know if it enlarges, but increases its ability to metabolize medications. Because of that, multiple medicines will drop their blood levels. So if you add Tegretol, got to be really careful because there's lots of drug interactions because it can decrease levels of other medications. There's tremor as well. All three of these cause tremor, you notice. Sedation as well, and weight gain as well. So really all three have a lot of similar side effects. Lithium, if they're on it for years and the toxicity in the kidneys builds up, their creatinine starts going higher and higher, and blood levels will often have to take them off, for that, and switch to one of these. That's sort of a common effect. There's a question from Gabriella: are the tremors renal, liver effects, or various mood stabilizers considered permanent or temporary? Yeah, look, that's a very good question. Are these various effects temporary or permanent? The tremors, definitely temporary, and dose dependent. So you stop the medicine, the tremor disappears, you put it back on, the tremor comes back. If the tremor persists, it probably was a essential tremor that got worse on the medicine, and the medication was just an add-on for it. But the tremors, by and large, go away when you stop or decrease the medication. The renal and liver effects are different. The kidney effects, once you damage the kidney is not going to grow back. You've got what you got for the kidneys. So we really watch the kidney functioning. If it starts to be affected, we'll call the nephrologist pretty quickly and ask if it's time to go off the medication, because you really don't want to mess with liver or with kidney damage. The liver is much more forgiving. Unless you're an end-stage alcoholic with severe cirrhosis, the liver does seem to grow back and does recover quite nicely. If you look at liver enzymes, SGOT, SGPT, they can be elevated up to 1,000, and within a few weeks they come back down to normal. And that's any medication that may be affecting the liver. So liver toxicity you worry about acutely, but once you take away the offending agent, it usually comes down. Kidneys, not so much. You got to be a little bit careful with that. Okay, next slide. Now these are mood stabilizers as well. So I've included them in the squeezer category. They're also in the heavy downer, the antipsychotic category. A lot of that is dose, how high a dose you're dosing it, and what are you using it for. But these are all the newer antipsychotics that we use pretty regularly for schizophrenia, for bipolar disorders, sometimes for depression, rarely for anxiety. You really shouldn't use these for anxiety or for sleep. These are mostly expensive. Some are going generic. Zyprexa is now generic. Risperdal is generic. The other three I don't think are. Somebody send me a chat if you think they are, if you can find evidence. But I think it's really just these two that are generic. So these two are dropping cost, but boy, these are still kind of horribly expensive with that. Seroquel might have gone generic. This one, I'll put a question mark until somebody looks that up and types in the chat. But most of these two are really expensive. Abilify, very expensive. Jungian, expensive. So Zyprexa is a good mood stabilizer, but there's a lot of weight gain. We see quite a bit of weight gain. And this really is how our awareness of the metabolic syndrome really came about. Metabolic syndrome is increased abdominal girth, increased weight, increased triglycerides, increased blood sugar. And any of these medications can cause that metabolic syndrome with weight gain, with blood chemistry changes. And that's pretty significant with some morbidity and mortality. People can have heart attacks, they can die prematurely, they're substantial, they can develop diabetes. These are problems. But these are also very effective, so it may be worth the risk of that as well. Zyprexa, though, does it the most. Of these medications, it's got the most weight gain, it's got the most metabolic syndrome, but maybe the most effective. It seems to be a little bit more potent as well. The Risperdal is kind of in between. It's got some moderate weight gain, moderate metabolic syndrome, but it's effective. And generics, we'll use it a fair amount of that also. Jan says quetiapine is indeed generic. So yeah, so these, let me erase that and put a check next to that. So these three are generic. I don't think Jungian is. And there's another comment. Len, 1871 first recommends the use of lithium. 1876, toxicity, falls in disuse. 1949, reintroduced. Okay. So 1871 wins. 1871 was the first one. And so both are kind of correct. And Jungian is generic. Okay, I haven't So these 4 are generic. So these are relatively recently generic, but not Seroquel XR, right, and that makes sense. XR would take longer. So these 4 are generic. I'm not sure if the price has dropped yet on the Ziprasidone, the Geodon. Anyway, keep going down. Seroquel also has a lot of weight gain, a lot of metabolic syndrome as well, and but very good for sleep and mood stability. So we might use Seroquel with somebody who's very agitated, you're not sleeping well, but again, you have to look out for weight gain on Seroquel. Geodon has a minimal weight gain. It's still in the warning list, but mostly because it's within the same category as the antipsychotics. So it's still on there, but you see much less. Geodon, you don't see much weight gain at all. It's more activating. That can be a problem, a little bit too energizing for some folks. But if somebody is oversedated on an antipsychotic, Geodon can be good for that. There's some EKG issues at times at certain dosages. So you have to watch EKG if there's another medication that can prolong what's called the QTC interval. But a good medication. We use a fair amount. Abilify is kind of nice in that there's very little weight gain. It seems to be a good overall medication. Maybe the first one I would use unless you need a lot of sedation. If you need sedation, Zyprexa, Seroquel. If you're just wanting to do mood stabilization or antidepressant effect and want to add an antipsychotic, Abilify is kind of a nice one for that. But not generic, so pretty expensive for that. Safris and Fanap, and I think there's even some new ones coming out as well, aren't really as researched as much for bipolar, maybe Safris a little bit more so. These are newer. We don't really know as well how patients are going to respond, but if you're stuck and things aren't working, it's not a bad thought to use these. Of course, they're not generic yet because they're so fairly new with that. Okay. All antipsychotics have substantial risks, and we've already talked about this some. So you really want to avoid antipsychotics unless you really have to, because they do have such negative effects. Tardive dyskinesia is very worrisome with these medications. Tardive dyskinesia is a dyskinetic motion, meaning the face, tongue, jaw, fingers, really any body part, but you see it most often in the face. You'll see a repetitive unconscious movement. Could be like a lip smacking, could be almost a tick, could be a chewing. You see a chewing motion in the jaw. You might see what's called a pin rolling motion in the fingers. It's not a twitch. It wouldn't be a tremor or twitch as much as a unusual repetitive motion. There's something called an Ames test, which has you run the patient through some various muscle tests, and you can pick up the subtle signs of tardive dyskinesia pretty well. So if somebody's on one of these medications, we'll do an Ames test pretty regularly. But that doesn't always go away. You stop the medication, it sometimes gets better, but sometimes it's permanent. So again, that's a serious side effect. Elderly patients have, particularly with dementias, there's warnings in literature that it may not be effective. It may cause stroke, and it may cause death. And of course, that's not good to read in the warning handouts. So most people are really trying to avoid antipsychotics in the elderly, but yet if you have a patient who's behaviorally problematic, impulsive, agitated, it's hard not to use these medications sometimes. But you'd want to try first a benzodiazepine, a sedative, Ativan, something along those lines that might decrease agitation before going for an antipsychotic, which is much stronger for that. Metabolic syndrome we already talked about. So again, that's increased weight, increased abdominal girth, blood sugar, cholesterol, diabetes, etc. Let me run through the questions. I saw some questions there. Any hands raised? Let me first scan for that. No brave souls raising your hand. Okay. Under the chat item, are there any long-term studies concerning the effects of these medications and the propensity for the incidence of cancer? That's a good question, and if anybody has a better answer than mine for that, please type it into the chat box or raise your hand, and we'll call on you. I'm not aware of any studies linking cancer, with these medications, other than occasional kind of odd studies that don't seem to bear out, that we look a little bit further and they do more studies and nothing is really there. Obviously, that'd be very worrisome if these kind of medications were causing cancer. So not that I'm aware of, or if there are ones, the ones I've seen aren't consistent, verifiable, and there. If somebody has seen otherwise, though, type it in. Let me hear from that, or raise your hand, and we'll call on you. And then Jacqueline has another question. Do these antipsychotics take time to make their effects like antidepressants, or can they work overnight? That's a great question, and the answer is yes, meaning both, that the antipsychotic medications, let me go back to that slide, are both. They've got a quick-acting and a short-acting effect. All of these will rapidly tranquilize somebody. If you have somebody in the ER who's agitated, breaking things, attacking nurses, security guards, in restraints, maybe high on drugs, maybe not, there's two rapid tranquilizers you can use. You can use benzodiazepines, which are Ativan and Valium and those, or you can use antipsychotics, Haldol, which is an older one, or any of these newer ones as well. And they'll have a rapid effect if you use a high dose, rapid. You might use an injectable version, to give them a shot in the emergency room. But there's also a gradual effect. So if you stay on these medications for weeks, they build up just like the antidepressants and will have a positive effect that way. So it's a dual acting. You get an immediate effect within minutes, really, but then you get sort of a gradual effect too as you stay on the medication. So it's a little bit of both with that. Okay, any more questions? No hands raised, and no more chats. Okay. And I might have missed a question earlier. No, we got that one. Okay, good. So let's keep going. Lamictal, I put in both categories just to remind us that not only is Lamictal an antidepressant, and we talked about it in that category, but it's also mood stabilizer. It's got a dual acting. It's half antidepressant, half mood stabilizer. So again, it fits in that niche really nicely. If you have somebody who needs some antidepressant effects, but also some mood stability, it seems to work really well along those lines. Medications with questionable effectiveness in bipolar, you'll see mixed reports. Some reports say it works, some it doesn't. So these aren't my first line treatment for bipolar, but if the other ones aren't working or aren't working enough, I'll go to these medications maybe to augment, help out, or if they have a past response, they say, hey, Dr. Buser, I've tried Topamax before and this works really well. I might use them in that case. Topamax, topiramate, is a anticonvulsant. In fact, all of these are anticonvulsants. These are all anti-seizure medications. Topamax you have to be a little bit careful with. They call it Dopamax sometimes, meaning that you feel kind of dopey on it. You can have word-finding difficulties, can't quite remember things. And if that's significant enough, patients really dislike that. It's a horrible feeling to have with that. Some weight loss with Topamax. So some people use it to try to lose weight as well. That's a common reason with it also. So yeah, so we'll use Topamax sometimes with that, but not real commonly. Neurontin, gabapentin, also generic, is good with anxiety, maybe good with pain, particularly neuropathic pain. And we might use it with an anxious person with some mood instability. You can use pretty high dosages, up to 4 or 5 grams sometimes with it. Gabatrol I use much less, Trileptal less yet. And, so these I kind of use just if there's a patient that really says, Doc, I do great on these, it really helps. Or if I'm really desperate, I might move with these. But these are a little more common, but again, not as common as the others. This whole page is sort of less common for mood stability. So that's it for section 2. We'll be moving to anti-anxiety agents in just a moment. So let me first ask any questions on mood stabilizers before we move on. I'm scanning. I don't see any raised hands and no chats. Okay, so we'll go ahead and move on with that. All right, this slide is just to say that anxiety has a lot of different forms. And DSM-5, we're actually going to be restructuring some of the categories of that. In fact, we're going to do a talk on May 22nd on DSM-5, and you'll notice that in DSM-5, OCD is no longer a anxiety disorder. It's a obsessive-compulsive category in of itself. PTSD, I believe, has been moved to a trauma-oriented one. These three, I think, are still anxiety disorders. Nonetheless, they all carry some amount of anxiety, pieces, within them. And it's really important if you're treating a patient, not just say, oh, they've got anxiety, but what type of anxiety? Is it panic? Is it generalized anxiety? Is it social phobia? Is it OCD? Is it PTSD? And again, in our DSM-5 talks, we're going to do a whole series on DSM-5, starting in May and really going right through the summer. And we'll do DSM-5 overall, and then we'll do DSM-5 on depression, DSM-5 on anxiety, and psychosis. And we'll be able to go in really substantial detail into criteria and how you diagnose. But this is just to say, make sure you think through these and diagnose the correct anxiety issue. The best anti-anxiety agents are really antidepressants, meaning that other than sedatives, which we'll talk about, the Valiums, the Ativans, and Clonopins, which you try to avoid, the best medications for somebody with anxiety are, in fact, the antidepressants. They seem to work best. The antidepressants are non-addictive. They're usually non-sedating. They take a while to build up an effect, and that's important because the sedatives are immediate. So patients, you want immediate relief, but these take a while. So that's the biggest drawback of antidepressants. But they're much better long-term. So if you need a long-term treatment for anxiety, much rather have the patient on antidepressant than a sedative, like the Valium class. So all the SSRIs are good for anxiety. If you look at these 5 SSRIs, remember Celexa, as Rick Smoot reminded us, is 40 milligrams, not 60. But anyway, these are all good for anxiety, and pretty equally so. If you have anxiety, an SSRI is good. I would say I would go slow. You really want to go slow with an SSRI if you're dosing it for anxiety, much slower than you would for antidepressant. Because if you go right to 20 milligrams on Paxil or 20 on Celexa or even 10 on Lexapro from the very get-go, very often you get activation. They get really anxious and agitated, and you really want to avoid that if at all possible. So I would use 5 milligrams on Paxil. I would use 2.5 of Lexapro. I would even get a liquid and just get a cc at a time of one of these formulations. Some patients I'll use a dropper. I'll just give them 2 drops per day, increase up to 3 drops after a day, and then 4 drops until they can get up to a whole cc. And then if you go slow, nice and slow with these, you can avoid the activation and avoid some of the anxiety worsening. That's just a good thing to keep in mind. And then 5 non-SSRIs. You'll notice it's 5, not 6. Who remembers what the 6th is? Somebody type in the chat, why did I leave out the 6th non-SSRI? And just type in that one if you remember it, because these 5 are good for anxiety, but the 6th one isn't with that. So that includes Effexor, Pristiq, Cymbalta, Remeron, Vibrid. They're all good with anxiety. Of these, you've got the various niches still. So you've got Remeron is sedating, Vibrid, less sexual side effects, Cymbalta, etc. And there it is. We've got 2 people have typed in Wellbutrin. So indeed, Wellbutrin is not on this list because it's not that helpful for anxiety. It's good for depression and maybe even ADD. It's got some ADD stimulant-like effects with it. But for anxiety, with rare exceptions, I really wouldn't use Wellbutrin. I would use one of these other SSRIs. And again, you got the dosage range in there as well. Okay, so sedatives. We're going to do a poll on sedatives, and that includes Valium, Xanax, Klonopin, Ativan, etc. So Ryan is going to click over there in just a minute. And the question with sedatives is, are they used too much, too little, or just about right? So sedatives, Valium, Xanax, Klonopin, Ativan, etc. Are they used too often and are given too quickly by patients to cover up symptoms? Are they used not often enough, as many physicians have severe panic disorder and aren't treated with sufficient dosages? Or they're highly addictive and should almost never be used. So everybody vote. I'm going to vote too on that. We've got about 30 people online, Everybody vote, and Ryan, as soon as you're ready, feel free to close that out. That is a controversy. Benzodiazepines, which is the name, for the class of sedatives, can indeed be misused, or they can be underused, with that. And here's the vote. We've got a very clear mandate. 77% say they're used too often and are often given too quickly by patients and physicians to cover up symptoms. Somewhat less are saying they're highly addictive and should almost never be used. And a very small 5%, which is, what's 100 divided by 30? Yeah, that's probably just one person, says they're not often enough, as many patients are undertreated. The person that answered that is indeed correct on some level as well. I think all three are correct. If somebody has bad panic disorder, often physicians will treat that. So occasionally that is the case, but I think much more likely is what the majority are saying, which I think they're used too much. We're quite quickly using benzodiazepine sedatives, too quickly, and the family docs, bless their hearts, are under enormous pressures trying to keep patients happy with what they're requesting, but it's easy sometimes to use a sedative and do that. So you want to be really careful with that. I think it's important. Charles Daniel says Xanax has the best medication compliance. I don't know if there's research for that, but certainly I've seen that to some degree as well. Len says, excluding the very severe presentation of depression or anxiety, how do you gauge when relieving symptoms impedes a person's interior growth and process? Sadness or acedia may arise from the neglect of the self or the failure to attend to individuation can easily cast depression. Yeah, right, that's a very good question. That's actually a poll question we're going to be giving in about 15 minutes. I'm going to hold off on commenting on that, but I'll get back to that question, Len, and in fact I'll probably reread your comment on there because it's a good one when we get to that. But yeah, that's a very important point, especially in the Jungian circles. How are some of these symptoms telling us something and maybe necessary for our own growth kind of journey? Good. We just did that poll. Okay, good. So sedatives, benzodiazepines, and sleeping medications, again, use with caution. We're not saying don't ever use these medications, but you want to be very careful. It's easy to get addicted to these. In the 1950s, Valium came out, and how many stories and movies or songs we heard about kind of Valium in the 50s and being misused, and the housewives that were taking too much Valium just to deal with the stress of living in the plastic era of the 50s. 50s were great in some ways, but the dark side of the 50s was Valium had just come out, and physicians were excited that they had a very effective medication, not realizing how addictive and problematic Valium was. They're all quick acting. You give somebody a benzodiazepine sedative, and within minutes they're going to feel better. And if you give it IV, they'll feel better in seconds. Versed is a medication we use in anesthetic situations that has immediate effects to it. Patients like them. You get a buzz on them. They feel good. They're quick acting. They like them too much, so you got to be careful. All us prescribers have had patients asking for too much. They're addictive. They cause fatigue. They cause depression. Sometimes patients on large dosages of sedatives will come in with depression, and oftentimes I'm convinced that the sedative is causing the depression. They're on so much Valium or Klonopin that they're snowed by it, and the depression is from the sedative with that. So the pure sedatives, meprobamate, Charles Daniels, meprobamate was much darker. Yes, Charles is probably a prescriber from some time back. The barbiturates were highly problematic as well, and deadlier in overdose. I'm not talking about the barbiturates here, but the phenobarbital, the meprobamates. Those were used. I forget the era. Somebody could Google that and type it in the chat box. But my recollection is the phenobarbital, barbiturates were out first, then the sedatives, the benzodiazepines, and then the SSRIs and all that later. And the barbiturates, highly problematic, highly deadly in overdose, and that was probably a worse era. Valium was an improvement on that, but then was also, and then Quaaludes. Is that like a Quaalude is one of the questions. So, yeah, the barbiturates have some similarities and can be problematic. We almost never use them. I have one patient selling a barbiturate that's been on it for 40 years and swears it's the only thing that works, but we don't use barbiturates very much anymore. Barbara James, there can be wisdom in depression and anxiety for individuation and involve meaning and purpose for the individual. Yeah, excellent point, Barbara. Fully agree with that, and we'll get back to that point in just a little bit. So the pure sedatives, we've got the long-acting ones, Valium, then these other ones, Valium probably more often. I put the ones in red, the ones you see used more frequently. Mid-range, of half-life, how long they act in the body, Klonopin. Ativan and Xanax are shorter acting. That's usually good. Sometimes can be problematic because the short-acting ones get in and out of the system quicker. A long-acting one, a Valium, will kind of get in and kind of linger like that. The short-acting ones get in and then they get out. And as they get out, you can get anxiety, rebound, and feel the need to take more from that. But, of course, the long-acting ones have problems as well with that. So you're always balancing the half-life and how long they act. These are quick. These are longer-acting half-lives. Most commonly used, benzodiazepines, which some common dosage range. Again, these are just things you'll see out there, but it can be used more or less than that. Valium, Klonopin, Ativan, Xanax, Restoril. Those are some of the more common ones you'll see and use there. The sleeping medications, these are related. So they're all pretty similar to the sedatives, the benzodiazepines, but they're targeting more specifically the sleep part of the neurotransmitters. The benzodiazepine subreceptor is used more with sleep. The ones. These are very common. Ambien, of course, I'm sure you've all heard about Ambien. Very commonly used. It's generic now. As some of these other ones have just been coming out generic as well. And Ambien is pretty problematic. They just changed the dosage recommendation for women. Is now 5 milligrams. It was 10 for both men and women just in the last few weeks that came out. We've been seeing that clinically as well, that men or women, but women more than men, seem really sensitive to Ambien. Ambien can have a amnestic effect. People can sleepwalk, they can sleep drive, they can sleep eat, and all those are pretty problematic, especially the sleep driving. I've had patients who will take the car out while they're asleep, come back, it may or may not be an accident, and have no remembrance whatsoever of the driving that they did in the middle of the night. That said, it's very effective. It's pretty good at getting patients to sleep, but it's kind of mildly habit-forming, not as much as the Valium class, but it's still habit-forming, so you want to be really careful with that. Ambien CR came out right as Ambien was going generic, so the cynic would say that was because Ambien was losing its patent life. Ambien CR does last longer, so if you have a patient that's waking up in the middle of the night from Ambien, Ambien CR might be a little more helpful with that. Lunesta, somewhat gentler, less addictive maybe, not quite as strong as the Ambien piece, has a real pretty blue butterfly that you'll see in the commercials for it. Sonata isn't used that much, but it's actually a pretty decent medication. It's much quicker in and out. It's kind of like the Ativan. So if you wake up at 2 in the morning, you could take a Sonata, and it's going to be out of your system by the time you wake up, by and large, much more so than Ambien, where you could be really hungover or dangerous driving if you took that too late. Rosarum, minimally addictive, hasn't been that effective in my experience. We haven't had a lot of success with Rosarum. We were very excited when it came out, but it doesn't seem to have held its effectiveness through that as much as we like. These are non-addictive sleep medications, and these are really nice to be able to use, especially trazodone and let's say Remeron. All of these are very sedating, yet they are non-habit forming, and they're pretty much all generic. Even the Seroquel now is generic. Trazodone is nice. It has a broad, from 25 all the way up to 300. 50 to 100 is probably the most common. It's very good for sleep. It's sometimes has a hangover effect, but once you get used to it, it's not too bad. There's really minimal addiction, if any. Priapism, you need to be a little bit careful about. Priapism is a sustained erection that won't go away, and it's not a fun erection. Most men laugh when I mention that with trazodone, but it's a painful sustained erection. And if you don't get it taken care of through medications, and even ejaculation won't let it go down in most cases, it needs to be surgically corrected. So if you have priapism, you go to the ER and get medication before you have the surgeon operating, which is not good. That said, this is very rare. I've seen very few cases. I've dosed trazodone a lot, and even though we worry about that, it's quite rare, so don't worry too much about it. Vistaril is okay, but it's got a lot of side effects, and I don't like to use it too much. Remeron is very nice. It's an antidepressant, so if they have depression and low appetite and nausea, Remeron can be very useful for sleep. Seroquel, very effective. But, Seroquel is antipsychotic, so that long list of metabolic syndrome, of hyperglycemia, diabetes issues, tardive dyskinesia, that's a long list for, medication that you're really just using for sleep, and you've got things that are, less dangerous, there for it. So I wouldn't use Seroquel for sleep unless there's really another reason, why you might use it. Okay. Buspar is a unique medication in that it's really only anti-anxiety. Unlike the antidepressants, it is mostly used just for anxiety. There's very little antidepressant effect. It's non-addictive, and it's gradual. So it's a really good medication if somebody has anxiety and you want to avoid a sedative, but it's gradual. So again, unlike the Ativan, where you get immediate effect, Buspar is more like an antidepressant in that it takes really weeks to build up in the system. So you have to have somebody be patient with it, and it's safe, very few side effects. So it's a nice medication along those lines. Okay, that's it for anxiety medications and the sedatives. Let's pause for questions. So I will scan through the list for hands being raised. I don't see any hands out there. And any questions? There are a few questions on the Jungian aspects, which we'll be talking about soon. I don't see any questions on, okay, any anxiety medications. The stimulants, I don't want to talk too much about, but I'll run through just a few slides on it. They're safe and well tolerated. They've got really good efficacy. Side effects are there, but can be often managed. There's some long-term effects that you want to worry about, especially in children. Growth can be delayed. There's different types out there, and the optimal dosing isn't always weight dependent. So you can't just determine the dosing depending on how much a child or adult kind of weighs. Things to worry about: decreased appetite, weight loss, growth suppression. There might be catch-up growth. If they stop the stimulant for the summertime, sometimes they'll do better and then catch up the growth at those points. Motor or vocal tics can be a real problem with them. Insomnia, headaches, tachycardia, blood pressure. So you want to be a little cautious with the stimulants. There's two main classes. There's the amphetamine and the Ritalin. So with the amphetamine class, that's the Adderall and Dexedrine class. We've got short-acting, Adderall and Dexedrine. We've got intermediate-acting, Dexedrine, Spansules. We've got long-acting, Adderall XR, Vyvanse. So again, how much of the day are you covering? For children, that makes a big difference because the school nurse has to dose it if you do a short-acting one, and often there's a stigma and the kids don't want to have to do that. So the longer-acting Adderall XR can be an improvement for a school-aged child with that. Or an adult that wants a smoother medication that kind of lasts through the day and doesn't have a lot of ups and downs with it. Ritalin has, again, short-acting class, intermediate-acting, and long-acting. I won't read all the names. You guys can read these now, or if we send out the handout PDF to you at some point. But Ritalin is the quick-acting one, and Concerta is a good example of the long-acting one. The Daytrana patch is kind of nice in that it's a patch you put on the skin, and you can bypass the stomach, and you can tear off the patch and really dose how long you want to work through the day by that. Once you tear off the patch, it's still going to be in your system for a while, but it's got a little bit more flexibility with that. There can be some reactions at the skin site from that. Okay. Then Strattera is a miscellaneous class, meaning that it's not a stimulant, a pure stimulant like Ritalin or the Adderall medications. So it's not Schedule II, so it's got some less restrictive DEA requirement, be safer for use in patients with substance abuse. This one's actually a norepinephrine, it's a NE, norepinephrine reuptake inhibitor. So it's just like the serotonin reuptake inhibitor. Strattera is a norepinephrine reuptake inhibitor, and that seems to be similar to a stimulant in some ways with ADD. Psychotropics and pregnancy. Again, I don't want to spend too much time on that either, other than to kind of talk briefly about the pros and cons with medications and pregnancy with that. And if you look at the FDA, they categorize the various medications into different risk levels, and there's A, B, C, D, and X. And A is the safe one, so A is generally acceptable during pregnancy. You can have them on medication while they're pregnant without too much concerns. B is maybe acceptable. There's some evidence of negative effects, but it's a little bit fuzzy. C is you can still use it, but use it with caution. And we'll come back to C because C is the most common one for most of our medications we use. And for that one, if the benefits outweigh the risks, go ahead and use it, and vice versa if the risks outweigh the benefits. Animal studies can show risks, or some human studies show risks, but they're not so severe that we're saying you absolutely can't use it. D, you really want to avoid D and only use it in life-threatening emergencies. So if it's the only medication that's going to keep them safe and non-suicidal, maybe use it. But you really don't want to use a category D. We've got some of those in psychiatry. X, use. X, don't use during pregnancy. That would be thalidomide. The thalidomide, children from way back, the thalidomide babies missing arms and legs. That's a medication that I'm sure is an X. You just never, ever use it unless you want to get sued and lose your medical license. So if you look at the different medications, again, there's 5 categories, and C, which is most of ours, is right in the middle. A and B are nice if you can use an A and B in pregnancy. D and X, you really don't want to use. C, you weigh the pros and cons with that. And virtually all our antidepressants are category C. Paxil is D, so you don't want to use Paxil. Cardiac anomalies and neonatal complications. Some OBGYNs will say Wellbutrin and Zoloft might be a little bit safer. That's kind of controversial. MAOIs, we haven't talked about it at all. Those are monoamine oxidase inhibitors. Those are very rarely used. I haven't had a patient, probably in a good 3 or 4 years, that's been on MAOI. But again, this is more of a historical medications. Occasionally we'll still use it, or MSAM, which is a newer version of that. We've got some patients that will take that. But there's little data on safety with MAOIs. Mood stabilizers, look, they're almost all D. So that's a real problem. Lithium's D, heart defects, Epstein-Barr anomaly. Depakote is D, get neural tube defects, spina bifida. Tegretol, same thing, neural tube defects. And these are significant, 2% there, 1%. This one's less than 0.1, but it's pretty significant. It's a severe anomaly with Epstein's. And so you really want to try to avoid that as much as possible. Lamictal is category C. So, Lamictal, kind of looks a little bit better for mood stabilization if possible. All antipsychotics, or I'm sorry, most are category C. And, these are a little bit older, so there's a little more experience with those. Giordano and Abilify are newer, so there's less data. But there's still issues, neonatal issues, gestational diabetes, et cetera. Again, can't see. Then benzodiazepines are D or X. So that's a real problem if you have somebody with panic disorder who's been on a stable dose of a sedative for a while. You have a risk of cleft palate, which is not good, and you want to be very cautious with their use. So really, you've got to talk to the OB. If somebody's needing really any antidepressant or antipsychotic, you want to talk to the OB doc and get a sense of what they feel for this patient is reasonable. But you're going to try to avoid the benzodiazepines as much as possible. Buspar is category B. B is nice, so if they did well on Buspar with anxiety, you might be able to change them over to Buspar with that. Hypnotics, mostly Cat C. Ambien may be safer. That's, a question mark, not really sure. Okay. And lactation is easy because they're all excreted in the breast milk, and not easy. It's actually difficult, but the theory of it is clear, because really all the psychotropics are in the breast milk. So they've done studies, and any medicine that we give is going to be in the breast milk, which means it'll be in the baby because the baby is drinking the breast milk, if you're breastfeeding. So we're left with a dilemma. If a lady has significant psychiatric symptoms and is postpartum and wants to breastfeed, you really have three options. You can breastfeed and avoid the medications, but that might cause relapse, obviously, and significant morbidity. You can bottle feed and stay on all the meds you want, but bottle feeding isn't as good, and it's pretty clear that the just the immunoglobulins and the bonding and all kinds of reasons why breastfeeding is helpful. But if you're worried enough with the medicines and really needed them, it's not wrong to choose that, but there's pros and cons. And then, of course, there's the third, which is to breastfeed on meds and monitor closely. So you'd want to be careful with that. With this one, you'd want to talk to the pediatrician. So talk to peds and really ask them, what's their opinion? Are they okay with the neonate and doing this, et cetera? But you want to ask the peds docs about that. And, of course, you want to use the lowest dose possible, because the less the dose, the less in the breast milk. And maybe even time when you dose the medicine versus when you breastfeed, although that's kind of difficult for most women and babies to time it. Okay, so here's the Jungian. We're going to get into the Jungian issues. We've got about 10 minutes left, and we'll be talking about that some. First, though, please raise your hand if there's anything so far they want me to cover before we get into some of these burning questions that have been there as well. And I think I have a poll question. Yeah, so feel free to ask or type out a question. Ryan, in the meantime, go ahead and pull up that poll question, and we'll put that up here. This is going into the last section of our talk, which is what are some of the Jungian principles? We've talked a little bit on the fly with it, but I want to spend the last little bit looking at some of these issues, and hopefully have a little bit of a dialogue. We can open up some microphones if people want to talk with that. So psychosis, such as hearing voices or seeing visions, is a psychiatric emergency that should be evaluated and medicated ASAP. B, possibly a spontaneous breakthrough from the unconscious and should be explored through associations and active imagination, i.e. Jungian principles. Or C, is a possible breakthrough from another world, such as life after death, or even, that shouldn't be event, but even visitors from another plane of existence. So a psychosis, a psychiatric emergency to treat, is it something that should be analyzed and looked at from a symbolic approach, or is it even more of a New Age piece? So go ahead and vote. I'm going to vote right now, and Ryan will pull that up shortly. Because this really gets into some of the questions that we want to talk about in this last little bit, which is how do you balance psychiatric symptoms being meaningful for the patient, being important to their individual situation, versus sorry, the poll came up, versus something that needs to be treated medically. So if you look at the poll results, that should be on your screen, and by far, 71% say that it's a spontaneous breakthrough from the unconscious that should be explored through associations and active imaginations. That's the Jungian kind of thought that psychosis is symbolic and we need to look at it. 23% say it's a psychiatric emergency and should be treated. And 4.7, say that it could be other, more of a, not necessarily literal, but another kind of spiritual event occurring with that. We had 75% of people voted. So that's good. And the poll really wasn't fair, with that. Go back to the presentation. I don't know if I have more slides on that, but we'll hold on that. I'll put up the poll question, Ryan, and we'll kind of keep the slide on the poll question for a little bit. The poll question wasn't really fair with that. There really ought to be a D, but I didn't want to put it down because I thought too many people would choose it, and I wanted to make it more controversial. D, which I think is probably the best answer, is it depends. I mean, it can really be either. If you have a patient in the emergency room that's psychotic, oh, cute, Ryan just typed that in. Thank you, Ryan. If you have a patient in the emergency room who is clearly psychotic, convinced, aliens have invaded their home, that's hearing voices, the voices are telling him to kill people, and etc. I mean, that is absolutely A. That's a psychiatric emergency. None of us are going to say, well, why don't you free associate to the murder impulse and say, you're going to hospitalize that patient and do what you have to. Now, later, you might analyze some of that, but not, so that patient would be absolutely emergency. If you have a long-term client that you've been doing psychoanalytic work with for some time, you've been doing dream work, active imagination, exploring symbols, and they have a hallucination. They see an image during waking hours that's sort of powerful, but lasts 5 minutes and goes away, doesn't occur, happened right after they awoke from a dream or after they read a passage from the collected works of Carl Jung, and they have this image. We're not going to throw that patient in the hospital. We're going to hopefully look at the unconscious material that's breaking through with that. So it really depends. How strong is that psychosis? Is it a really strong psychosis? Well, yeah, gotta get them in ASAP to the ER. Is minimal, and what kind of work and what context and all. Or this. I don't want to say it's impossible for unusual ESP outside phenomenon. Many patients believe in that, and who knows what life after death involves. I mean, there could be a visitation after a parent dies. You have a hallucination of a parent. That's both a normal psychological event, but it could be a spiritual touch from the other world. So, really, all three of these, could be options, with that. So, should we medicate anxiety? Should we medicate depression? Should we even medicate psychosis? With that. What are your all thoughts? I can talk a little bit further on that, but anybody want to raise their hand, open up their webcam, and talk about their thoughts? There's some chats. I'm going to be reading those in a moment and maybe commenting on. But what are, let me just flip the slides. Yeah, let me talk a little bit on those last two slides. Illness as a spectrum is really a DSM-5 talk. We'll talk about next time. As we've sort of already said, should we medicate these? It's a hard question. It really depends, and really how distressed is the patient, from these symptoms. How overwhelmed are they? And really, the patient's decision, unless in the ER and they absolutely need it. But the patient will also guide: are they willing to explore it in an analytical framework, or are they unwilling and really just want medications for it? So, any hands raised? Nope. Let's go to some of the chat questions. Got about 5 minutes left still. Barbara says, necessary breakthrough to balance adapted false self to manifest the authentic true self for personal vitality, moving into brain consensus to right and left brain balance. Yeah, a little bit cryptic, the writing, but obviously you were just kind of throwing out some bullet points, with that. Yeah, a very Jungian piece of what is this balancing, what's breaking through from the collective unconscious, and then what is that balancing towards, what's compensatory to it. And again, that's looking at what are the symbolic natures of it. What's another one? At some point, could you speak of the difficulties inherent in combining the prescribing of medications to analytical therapy? And that's from Jan. And yeah, that's really what we're getting at as well. And that overlaps with what we do here in our office quite a bit. I'm a psychiatrist, but really about 3 to 4 hours of my day is involved in analytical hour-long sessions. So if I work 8 hours, 3 or 4 of those are medication-oriented refills and evaluations. Another 3 to 4 hours are hour-long psychotherapy sessions, many of which are analytical in nature. I'm not a full analyst. I've been through a clinical training program in Jungian psychology, and I integrate a lot of Jungian principles into that. So how do you balance the two? As a prescriber, I try to separate that of the first or last 5 to 10 minutes of a session, if needed, would be on the medications, and I would look at the medications, and then I'll even kind of close my iPad or my notes I'm taking and say, okay, my doctor hat is done. We're going to shift gears. How are you really doing? What's going on? I'll actually transition from the medication part to the other part. And sometimes it might be complex, and there's 30 minutes of medication work that we'll do, and then we'll transition. Others will integrate it more fully. To me, it works well. Doing in-depth psychotherapy, and medications. But it does open up complexities with that, both in the transference because you're the doctor persona more, but also in how are you dealing with symptoms. Are you letting them go through the dark night of the soul? This last slide, especially with depression, when is it a dark night of the soul that needs to be gone through and understood through its symbolic and transformational elements, or when is it a clinical syndrome that needs to be medicated? And again, it's the D, I guess C in this case, but depends. It really depends with that. Often it depends on the severity. Are these overwhelming symptoms that are incapacitating for the patient and they really desire a medication to help them through it? Or is it not as severe, and that dark night of the soul is the call they're feeling to go through that, with that. Lara, if I'm pronouncing her name correctly, says, how much is malnutrition and these kind of breakdowns correlated? Yeah, and that's a good point that she's bringing up. That there are a lot of other factors with this. I don't want to talk about just medications or psychotherapy as the only elements within recovery. There's really a long list of things with that. There's diet, which is huge. What is the patient eating? Is it balanced? Is it nutritional? Is it junk food? Is it all sugar? And there's a lot of chemicals. Well, what are they putting in their body? There's diet. Exercise is huge. What kind of exercise are they getting? Sleep. How much sleep are they getting? Spirituality. Where are they in a spiritual walk? Is it meaningful to them? Is it not? Is there an existential aspect of the depression? Social aspects, their marriage, their family, their children, work stress, physical pain. I mean, the list is infinite. We could spend as much time as we could on listing and brainstorming the various aspects of that. So when you're dealing with depression in particular, but really any of these symptoms, you really need to dive into the wide range of factors that could be causing or worsening that. And so, again, that's that detective piece of what we do, of really breaking apart the aspects of the client's life with that. Another comment just popped up. Let me see if there's any brave souls that want to speak. Nope, mostly introverts tonight. That's okay, other than Rick, who is a little more extroverted, I suspect. And we'll need to wind down soon. There's probably not really time at this point for another webcam. Len, how do you gauge when relieving symptoms impede a person's interior growth? Can you suggest things a therapist might wish to consider, or what you consider when discerning if medication will impede a person's growth and when the symptom relief makes sense? That's a great question. And Len, if you're near a microphone, if you want me to turn on your mic, I'm kind of wondering if you have any thoughts about that. And in fact, I'm going to try to. There you are. Len, can you hear us?
I can.
There's feedback. Turn down speakers. If you have a speaker, you can turn down.
Is that any better?
I think so. Yeah, that's much better. Well, no, turn down your speaker even more if you can.
How's that?
I think that's good. Yeah, go ahead. Yeah, that's much better. That's perfect. But tell me your
I was actually hoping to pick your brain, Steve. I really don't know, except the one that typically worries me more is anxiety, since I'm often inclined to think that letting somebody sort of marinate in their anxiety in order to gain some mastery is something that we unfortunately deprive people of. But that dark night of the soul is a tougher one, I think, but I think it still applies. So no, I was just wondering if you had sort of guidelines that you use when trying to maybe refrain from prescribing in order to see if it's going to evolve in a way that's going to be deeper and richer.
That's a great question. Yeah, good. Let me talk a minute or two on that, and then we'll probably wind down in just a moment. And go ahead and re-mute yourself if you haven't already. It's just to avoid the feedback. Yeah, I think you're right, Len. The anxiety aspect of it may be even easier to see. Psychosis, probably the hardest to especially a severe psychosis. Depression in between, there can be a lot of pain and suffering. Anxiety even more so. Of course, overwhelming anxiety, panic disorder, where they're agoraphobic, can't get out of the house. Again, that's, you got to help get them out somehow. But yeah, when do you let them stay in the anxiety and kind of marinate? That's a nice, word in there. And I think you'd want towards that, particularly if you're in step psychotherapy that you're really exploring things with. You really want to avoid medicating anxiety too quickly and really see what is anxiety about, because anxiety is a motivator. It motivates them to change, motivates them to look at symptoms. It allows them to go deeper into pieces. And you're right, if you cover that over, give them Xanax or Valium or Klonopin or even SSRI too quickly, hasn't allowed them to really go through that.
And then, Steve, let me just add the one thing that I sometimes use as a guide, and I don't know what other clinicians do, but if a person comes already seeking therapy and they go through an episode in their life that provokes their anxiety, and I have some relationship with them, I'm much more likely to use the holding environment, if you will, to allow that to mature and to season, versus, I think you made a good point at the very early part of your talk that so many people come already with a high expectation that they want immediate relief that, I don't think it's particularly profitable to position yourself as the one to convince people that they should endure some suffering if they came pretty ready to simply get the quick fix,
Yeah, right, exactly. And I think that's really well said. It really depends on the type of work and where you're going. And, ultimately, on one level, not completely, but it's really the patient's decision, too. There's nothing wrong with us saying, we could give you a mild anti-anxiety agent, low dose to help you through this. We'd ask that you only take it when you really need to, but avoid taking it too often. Or we can just see where this goes, of journal when you're feeling the anxiety, look behind it, try to go deeper and, see what the patient, wants. And if they say, doc, this is overwhelming, I really need something occasionally to get me through it, well, then that's different. So it's not only, where we seeing the therapy go, but we want to kind of go with the patient with that as well. Let me read a couple of chats, and then we'll probably wind down. We're just a tad over, about 4 minutes over, so I apologize for those of you that have any engagements need to leave too. But let me just close with a couple of the last chat comments, and then we'll kind of sign off in a moment. Medications are helpful to balance the brain to restore birthright health. For individuation into more personal wholeness, combination is an art to explore. Yeah, that's well said, and I really see the truth in that as well. And then last comment, from Richard Smoot. Sometimes benzos can serve as another avoidance approach for the patient with anxiety, and as a CBT therapist, I sometimes encourage the patient to not rely on them. Yeah, absolutely, and Rick's quite right. That really goes into that same kind of category with. It almost doesn't matter what kind of psychotherapy you're doing, whether supportive, whether explorative, Freudian, Jungian, and CBT. And in CBT, there's a common awareness that if you medicate with benzos, the sedatives, the Klonopins and the Ativans, there's sometimes something called state-dependent learning, that you learn how to relax with a benzo on board, sedative, but it's harder for you to relax when it's not there. And you really want to try to learn other techniques. In this case, CBT, cognitive behavioral therapy, that Rick may be doing, or Jungian explorative symbolic therapy. Either therapy, it's helpful to try to not over-treat anxiety and to let that work through really on its own, either through the cognitive behavioral techniques or through the depth exploration with that. So we'll sign off in just a moment. Just to remind you, we appreciate everybody coming today. Again, this is new software technology that we're just trying to integrate. This is the first time we've had a webinar of this format that includes video cams. So hopefully having my video image up there was helpful and not too distracting. In the past, we've done PowerPoints with the audio over. I think it's delightful to see other people sign on, and Rick, I appreciate your signing on with the webcam. there's a nice community kind of aspect of this to engage with it. Our next along this line is May 22nd, which is a Wednesday, I believe. We chose May 22nd because that's the date the DSM-5 is released. The APA, American Psychiatric Association, won't release any copies until May 22nd. So we're doing our homework to learn as much about it as we can before it's released and really give a nice summary of some of the changes that are coming about in DSM-5. We'll be looking at that then as a series. We hope to do, after that first one, a series then on the DSM-5 as it comes out. So we'll do depression section, anxiety section, and really have a chance to go deep with that. And I would love it if this becomes, that one becomes a clinical aspect where we can meet in this format. People can ask questions. We can share cases as long as they're confidential and aren't disclose any confidential material, and we can really go deep into some of these diagnoses. We're not giving up on the Jungian piece whatsoever. We've got a number of good Jungian topics coming up as well. This will just be a side clinical piece with the DSM-5. So with that, let me read one more comment. Barbara James says, I think this is great. So thank you, Barbara. I think it's great too. I really like this kind of format and being able to engage with people. And thank you, Barbara, for all the comments. You were one of the folks that gave a lot of comments. I know a lot of the others did as well. And it's fine if you just hang out without commenting, but we really appreciate that. And thanks for the warm participation from everyone, Ryan Deegan says as well. So with that, I will sign off, and we will see, hopefully, many of you in May 22nd. There might be, before I sign off, there may be one soon or two. We don't have it posted yet, but we're trying to pull off a San Francisco one. Ryan, type on the screen what the date of that is, if you know what that is. I'm blanking on it, but we're testing the software, and we're trying to get that one going. So May 4th, right. So May 22nd is the next webinar like this that I'll be hosting and presenting on. But on May 4th, if we finalize last few details, which is getting to be last minute, but we're hoping to do so, we will be broadcasting from 1 to 8 p.m. Eastern time, which I apologize for the 7-hour block of time. There's going to be a break in between. But San Francisco is having a really neat day on the Red Book, and they're going to be saving Jung from the Red Book, or vice versa. I think both are in the title. And it should be pretty neat. It's a long time to be in front of the computer, but if you sign on, you can just watch however much as you want, and then you'll have the whole 6 hours that you can break up into hour bites, throughout the rest of your life, if we can keep it up on the hosting as much. So you'll be able to watch it in bits and pieces. But think about that one. We'll get that advertised hopefully in the next few days with that. And otherwise, that should be it for the next two coming up. Okay, so this time I really am signing off. Again, I want to thank everybody for participating, and we will see you hopefully in a couple weeks. All right.